Thank you for the privilege and honor of giving the Richard Agababy an emergency airway lecture at SAM. I wish I was there in person. Instead, I'm giving this lecture from my kitchen. Now, there are some benefits of giving a lecture remotely. One is you can choose settings and you can click a button that will touch up your appearance, which can be beneficial. The other thing you can do is you can choose your own background. Speaking from your kitchen alone is very different than speaking on stage with hundreds of airway enthusiasts in front of you. It's just hard to carry that energy. So I'm trying to bring that energy by having a Rolling Stones concert audience in my background with Mick dancing there in the background. And this is in part a tribute to Charlie Watts, who recently died. So human factors and system design in airway management. An alternative title for this is The Dangerous Airway, as it relates to emergency departments, emergency medicine, but really in acute care in general. So this is where I live in Nova Scotia, in Halifax, Nova Scotia. It's a beautiful place. It's been a very, very safe place to live. And these pictures are of my cottage in the middle of the province on the Medway River, a place of refuge for mind, body, and soul. This is where I live on the interweb. This is aimairway.ca. And I was very active on social media for a number of years. And December 31st, 2020, it was just time for me to take a break. It was just a personal decision. Occasionally I miss it, but for the most part, not. And maybe I'll be back. I think it does add value in some scenarios. We'll see what happens in the future. Conflicts and disclosures. The only disclosure I have is that looking after a sick patient and managing their airway still causes anxiety. And over the years, it's contributed to gray hair and bad hair days. It's not a negative thing. Having anxiety going in to look after a sick patient can be a very motivating thing. It motivates you to want to be better and to improve your performance over time. I do want to acknowledge the fact that COVID-19 is still raging around the world and affecting so many patients, families, and healthcare providers. I know people are tired and exhausted, and just a second to say thank you for doing what you're doing. COVID's caused us all to reflect, to look in the mirror, and looking in the mirror as a person, as a partner, as a family member, as a colleague, as a clinician, and as an airway provider. And one of the things that many people have started asking is that, are we good enough? Are you good enough to provide safe and competent care for not only your patients, but for those around you, given these very difficult times? And fear has been very prevalent, and fear is very motivating, and it motivated me to pursue a specialty in emergency medicine. I finished my internship on a Wednesday, and that Monday I was working as a GP, and that night in the emergency department. And I guess I was shocked into the specialty when I realized I didn't have the skill set, the comfort, confidence to look after the patients I needed to. Ultimately, I did my specialty training in emergency medicine, did a master's in health professions education, and my focus was on procedural skill learning, and the procedure I was focusing on was airway management. And then I returned to Nova Scotia as an attending to a place that had this very, very positive relationship amongst the specialties of emergency medicine and anesthesia. And it was a collaborative experience with numerous people being dual trained. And I started practice, and I thought that I would be comfortable with managing anything. And what all of us realize when you've been in practice for some time is you continuously are humbled by what you're presented with. And what we need to do is be human and recognize our strengths and weaknesses, and more importantly, how to address them. Another factor that's been prevalent with my career path has been stupidity, and there is no corrective click button to hit on Zoom for this. I've got numerous examples over time. Perhaps the one that many people might be familiar with is that I think I have the most instrumented upper airway for educational purposes, whether it's by others or by myself. But it has helped me and others understand how to be a better airway management provider. So whose job is it This is one of the things I did find a bit ugly on Twitter and other places, is that there was this renewed turf war that started, and I would just want to park that. I'm very proud that the Society of Airway Management is a very inclusive society with representation from emergency medicine, anesthesia, ENT, and other specialties. And it's a job of the person who's at the patient's bedside when the patient needs their airway management. It's that person and that team that needs to provide that care. It doesn't mean that you don't call for help, whether it's within your discipline or outside. But I don't want to get into any badge competency arguments, certainly in this talk. This is just another example of the collaboration in our institution. And again, one of the system messages that we need to do is foster, acquire, and maintain these relationships between providers, whether it be in anesthesia, emergency medicine, and critical care, and other specialties, because we're better together. This was a paper that was published in an anesthesia journal, but again, it was a collaborative paper from our institution of both emergency medicine and anesthesia. We all have to recognize that we have to step out of our usual uniform. And this was a nice article describing how that affects our performance sometimes and our anxieties about doing that. It was around the concept of the temporary surgeon discussing anesthetists faced with performing a front of neck airway, a cricothyrotomy. I think this is helpful to look at this in a little bit more detail. So I'm not an anesthetist, but I'm quoting from the paper, is that identity as an anesthetist, like in any specialty, is related to the fact that you have specialty training and that you have a context and environment that you are used to. And it's somewhat controlled, even though sometimes there are days that are uncontrolled. And then on the other side, if you're faced with something like a cricothyrotomy, they're suggesting this role as a temporary surgeon. And the challenges you have is your concerns about being and doing something else, and that you're going to cause harm to your patient, and that this procedure that you're doing is considered a failure within your specialty and in reference to your own performance. And you have to reconcile these differences and train to reconcile these differences. And it begins with accepting the fact that this is a necessary procedure. This is a necessary procedure that you need to be good at, and you can't just rely on experience being your teacher for things that don't happen very often. You need to do deliberate practice. You need to spend more time than you do other things, to attain the confidence and attain the competence required to do this successfully. It is somewhat different if I were to apply this to emergency medicine, because the specialty is all about being the temporary but often definitive something else, right? Being a definitive or temporary anesthetist, cardiovascular surgeon, psychiatrist, orthopedic surgeon, whatever it be that day. And we're not accepting doing this, at a level less than what would be acceptable in other scenarios. Our training is meant to address that. And we're comfortable being in these temporary roles where others might see us as wearing somebody else's hat. It's part of our job and part of our comfort in stepping outside of what is considered normal for many. There's been for many over the past year, a bit of an identity crisis in emergency medicine, and hopefully this is being resolved and has been resolved over time. Emergency medicine and being an emergency physician, you need to be able to look after sick patients. You need to be able to manage their airway and do it very competently. There's a term called the resuscitationist, and I don't want to get into this, and I have some issue with that term because it somewhat implies that we are not, as anesthetists or emergency physicians or others, we're not resuscitationists. And it's part of our discipline. I think the intention of this term was to say that you can't just rely on experience alone, that you have to deliberately acquire and seek out opportunities to learn and be good in looking after these sick patients, because we're not doing this every day, multiple times a day. Doesn't matter what your specialty is. This is a t-shirt a bunch of us made. It's emergency physician, I resuscitate, and you can put whatever specialty you want instead of emergency physician. Our goal in managing airways isn't necessarily to always put the tube in the first time. Our goal is to improve patient outcomes, and we don't necessarily measure this as much as we should. And this is going to be a closing argument from a system perspective of what we need to focus in on more. Much of our time we discuss the difficult airway and appropriately. And historically, that's been framed around anatomy and pathology, and that helps us in terms of decision making of how we're to proceed, either do an awake approach or an RSI. And to really have those choices, we need to have things in our toolbox, equipment and skill to use those various things. So in emergency medicine, we've become very comfortable in performing an RSI, but you can't call it a toolbox or an airway card if the only thing you have it on is equipment to do and procedural support to do that. Otherwise, really what we're doing is we're gambling, and we're doing what's easiest for us, but not necessarily what's best for the patient. And I've spent a lot of time over the past several years speaking about this, trying to help people appreciate the fact that an awake intubation is a realistic approach for caring for our patients. When I talk about this, I talk about the right occasion, the right procedure, the right gear, the right prep, and the right execution. And for those of you who know me, I've got a passion for cooking Texas barbecue, and particularly making brisket. This is my online mentor. I've never met him. I've never eaten at his institution in Austin, Texas. This is Aaron Franklin. But it's all about what I said in those previous slides, spending the time to make sure you have things right, to have good tender brisket. If you just take a tough piece of meat, throw it on a barbecue, and lift up your barbecue, a number of hours later, you're going to be disappointed. So we want to bring that approach, bring the brisket to the resuscitation room in the same way, but make sure that we have an appropriate toolbox and equipment and skills to look after whatever we're going to be presented with. So anatomy and pathology help us decide how we're going to proceed from an approach perspective. And more recently, we've accepted the fact that physiology influences our decision making. And there's some literature coming out, and congratulations to the authors from Society for Airway Management Special Projects Committee, and their consensus recommendation on evaluation management of the physiologically difficult airway. And the big two that we most frequently encounter are the apnea intolerant patient or the patient in shock, but we're also talking about patients with RV strain and acidosis. Sometimes all these things are bundled into one patient. And certainly apnea intolerance is the reason why I'm doing awake intubations in the ED more commonly. So anatomy and pathology and physiology. And the last factor that influences our decision in terms of our approach is cooperation. And obviously be naive to think that we can move ahead with an awake intubation unless we can either somehow facilitate cooperation or the patient is intrinsically cooperative. If it was as simple as this, assess their anatomy and physiology, no difficulty predicted as a gestalt, do an RSI. If there's difficulty, then you do an awake approach. Life would be easy, but life is not like that. We do have to layer in other things, and that layering in is the ability of the patient to be cooperative. And they might be uncooperative because of their physiology is deranged or because of substances that they've taken, and that they don't always present like this patient here, willing to accept whatever you're going to do. And sometimes they're more aggressive, and sometimes you have to do something about this or change your approach entirely. So that was using these three components of the triangle: anatomy, pathology, physiology, and cooperation, to help us make decisions. But in general, for airway management, what we want to do is optimize these, whatever our approach is, to ensure better patient outcomes. This is the focus of a unsolicited editorial that Rich Levitan and I wrote about redirecting the laryngoscopy debate to optimizing emergency airway management. There's just so much debate and discussion about devices. And, I use video laryngoscopy routinely. I teach it all the time. It's added value. There's no question it saved lives. But if we think a piece of equipment is going to be the savior for all airways, we're obviously naive. And I think we just need to park that a little bit and spend more time talking about how we optimize patients' physiology and other factors and ourselves and the environment to get better patient outcomes. And that's ultimately going to be where I'm going to take this talk from now, is that up till now I've talked about all patient issues. Now this is look in the mirror time. And one of the reasons why I think sometimes we have bad outcomes is really about us and our environment and not being able to optimize that. And this is the way I framed the dangerous airway. This is a paper that Jared Mosier, myself, Adam Law, and John Sackles wrote in a non-peer-reviewed journal, talking about the dangerous airway. And the focus at that time was, again, optimizing the physiology of the patient, the importance of that. I'm taking a broader look at this and the non-patient related issues and looking at the environment and how this influences patient outcome. And it begins with, are you optimized? as an individual, as a provider. I've presented this before. This is the psychological shock index. It's having some playful fun, but I think it's real. If your heart rate is greater than your patient's heart rate, it has the potential to influence outcomes. So if your PSI is greater than 1, your heart rate, your heart rate is greater than your patient's heart rate, that anxiety has the ability to influence your ability to perform. And we know this from different settings. And so why is it at Olympic Games world records are broken? Well, they're broken because of that challenge elevates performance. That arousal is positive. But sometimes that arousal can cause dysfunction and it becomes a threat and performance can decrease. And we have to recognize that. And the situation where that happens most frequently is in situations that don't happen that often for your team and as individuals. So halo events, high acuity, low opportunity scenarios. And this is the zone of simulation. And this is where we need to focus our attention and spend more time, disproportionately spend time on things that we don't do very often, because we can't let experience alone be our teacher. And the way to address this, the literature would support, is two things. One is to overlearn, and secondly, do what's called System 1 training. What overlearning means is that you need to be better than good. And yes, it provides you a buffer and some margin of error. But what it does do is you have to, in order to get that buffer, you need to seek opportunities and alternative opportunities that you're not going to get in the clinical world. And when you reach this state of skill mastery by overlearning, what happens is when you haven't done that for a while, your reascent to that skill mastery happens more quickly, and then the decay takes longer to occur. So these are the important features of overlearning. What System 1 training is learn as many and execute as one. So there are 11 steps in performing a cricothyrotomy. If I have to recall all of those to execute this, then the patient's going to die. Right? I need to be able to have that psychomotor memory to be able to do it. And you don't have to wait for these great educational experiences to do this, right? It's a matter of doing what athletes do, right? They do motor mental rehearsal without actually physically doing anything with the equipment that they would otherwise use. And you can use pretty simple stuff, again, to get that motor memory and solidify it, repeating it over and over and over again. So then when you skill transfer that, using tissue and increasing physical fidelity, we have the great benefit of using clinical cadavers that, are often indistinguishable from the human body. I mean, when you feel your finger entering the cricothyroid membrane space with cartilage surrounding it, you'll never forget what that experience is. And then you don't stop there, though. You continue to challenge yourself. You challenge yourself and the situations by creating a bloody airway, doing it on scenarios with thick neck. Now I'm going to ask you this question. I'm going to look in the camera and I'm going to ask you this question. Since passing the quiz, since being an attending, how often do you practice these things that people expect that you should be able to do very competently, but you don't get exposure to do, whether it's as dramatic as performing a cricothyrotomy or other settings? We often don't feel comfortable putting ourselves out there, and we need to put ourselves out there to have good patient outcomes. And when we look at other people in what they would call high-stakes scenario, whether they're high-performance athletes or they're concert violinists or fighter pilots, they spend way over 90% of their time practicing and relatively little time performing. What do we do in medicine? We spend the vast majority of our time performing and very little time practicing. And that it doesn't work, right? And we need to change that to get the outcomes that we're looking for. So difficult versus the dangerous airway. I talked about the provider and you. What COVID has done, there are definitely legacy issues of COVID, and one of the legacy issues of us focusing on equipment, being lean and mean in terms of what we bring in and organizing our equipment so that we can use it in a timely and safe manner, and acquiring equipment. And we were able to use this to leverage access to video laryngoscopy for our entire province in short form. The other thing that COVID did is it stressed the importance of support, and we all need that as individuals, as humans, and we need that as teams. It taught us to work together, taught us to optimize our team, to go through this experience together, but not just be thrown into it, to plan for it, to practice doing it, to use things like checklists and decision aids. Again, these are legacy items from COVID that will live beyond and hopefully improve patient care. In general, though, I think that we need to move away from responding to difficulty, where I've got to try to retrieve that information, to one in which we're routinely expecting difficult and dangerous airway scenarios. And that's easier to do, I think, in emergency medicine and critical care, because most of the time that's our context. But to do that on a routine basis, as opposed to trying to retrieve it, I think sets you up for success. And speaking of success, most of us, if you were talk about success or read the literature on airway management success, it relates to this: is the tube going between the cords, and yes, confirming by waveform capnography. But as a friend of mine has said, patients that don't get better or don't get ill because of acute plastic deficiency syndrome. I didn't say that right. I'm going to say that again. I'm not going to redo this video. But patients don't die from acute plastic deficiency syndrome, right? So what we need to do is we need to optimize their care. We need to optimize their oxygenation, their ventilation, and their hemodynamic status. And we know in every setting, in every discipline, with increasing number of attempts, there's increasing morbidity and mortality. And by reverse justification, our goal has been first pass success. And that's been the outcome measure that so many papers have used. This is a paper that many of us are familiar with, the one in the top left. There are several examples of this, and we're achieving in emergency medicine and in the pre-hospital setting even high first-pass success rates. This is a driver study comparing routine use of a bougie with to a stylet. And they had a 98% first-pass success rate, and that was the headline. But really, the headline that I think most of us has come to appreciate, that the messaging from this and other papers, is that was really about optimizing airway management. It was about an airway bundle. It was about a package that delivered this high first pass success rate. You know, they were routinely using video laryngoscopy. They were skilled at using a bougie and skilled at airway management, spent time training on it and using an RSI as their approach. But still, their first pass success rate without hypoxemia was 85%. And again, plastic doesn't make the patient better. It's about maintaining and improving their physiologic parameters. So I think we do need to redefine success. I think we need to move away and demand from our journals that we're going to look for a broader definition of what success is. Ultimately, ideally looking at patient outcomes, but other surrogate markers that include optimizing the patient's physiology. This is just an example of pre-COVID and post-COVID in a large tertiary care emergency center in Australia. And they, pre-COVID, had high first-pass success rates of 94%. And post or during COVID, they went up to 96%. Not statistically or probably a clinically significant difference. But one of the reasons why this went up is because they spent deliberate amount of time doing all the things we talked about up to this point, right? Optimizing their approach, practicing as individuals and as a team. Now, if you look at their rates of hypoxemia and hypotension pre-COVID and then during COVID, it went up as you would expect in COVID, because sometimes there's only so much optimization that you can do. Yes, you're going to ventilate the patient throughout the period of time during the induction time, but still these patients, we know that they crash more frequently than other patient population. So the right occasion, right procedure, right gear, right preparation, right execution, whether it's resuscitating a COVID patient or whether it's cooking brisket, the same approaches still apply. The difficult versus dangerous airway, in order to ensure provider safety and good patient outcomes, we need to pay attention to patient issues and environmental issues. I'm going to close with this because our province is a good example of a system that worked together as one. And what we did is the provincial guidelines for airway management was collaboratively published by emergency medicine, anesthesia, critical care, and IPAC. And we're using whatever resources that we use. The videos that were within this document were supported and in play on our website, aimairway.ca. And we took down all other material, as many other people did, to put up stuff to help those looking after these very sick patients. We published this paper about what we did, and I'm most proud of is when we started at the beginning of COVID, we set up this emergency airway management lead program where we took emergency physicians that were leaders in airway management, and we cut the province up. It was already cut up into zones, and these zone leaders for the emergency departments. We're there to help translate, to help make the guidelines relevant to these various institutions, and to try to establish consistency from one place to another. And they did on-site training, supported their simulation problems, facilitating access to equipment, and that's continued to this day. So again, a good example of turning a crisis into an opportunity and supporting airway management care at a provincial level. This is a plea, though, is that in order to really get where we want to be, we all need to monitor outcomes, ideally patient outcomes, but outcomes such as first pass success and first pass success rate without hypoxemia, without hypotension. It should be considered the standard. And I bring this up because a lot of places have felt threatened because they couldn't prove that they were doing a good job. And you're more likely to lose things that you don't own. And you need to own, the skill set that you say you own. And just as importantly, you're more likely to lose things that you can't prove that you own. So you need to do that by monitoring and documenting what you do. Expertise isn't about what you do routinely. Being an expert depends on how you manage your patients and yourselves and your team when things are out of routine. Complacency breeds incompetence. Slow down, be better than good. Let's turn crisis into opportunity. I have a lot of people to thank from an airway perspective, and they have been mentors and friends and along the way. Thank you, and all kinds of others that have helped me along the way. So thank you. You all know who you are. Be safe. Thanks for listening. Take care.